Dear colleagues, this is a totally unedited video of phacoemulsification of a soft cataract, and you are going to see every step of the surgery, and you will see where I fumble in several steps. Now, the eyelid margin is nicely covered by the plastic drape. A thorough wash of the ocular surface is given applying betadine 5% lotion. Betadine 5% lotion has been applied in the preparation room, 2-3 drops of it, and it has been kept for at least 3 minutes before it is washed out. Now, we have started the case. In this case, I am going to show my lens tilt technique. I have termed it as Mohanta's lens tilt technique. This is not a new technique. Dr. K.K. Mehta has termed it as lens salute technique. Now, the main incision 2.8 mm has been placed at a selected site. One side port has been made, and this is another side port. Viscoelastic substance has been injected into the anterior chamber, and viscoelastic substance has been applied over the epithelial surface of the cornea. Now capsulorhexis is being done. The anterior capsule has been incised with a 26 gauge bent cystatum. A capsular flap has been raised so that I can hold it easily with utrata forceps. The utrata forceps rests against the anterior lip of the main incision so that leakage of viscoelastic substance that has been injected into the anterior chamber, this leakage of this viscoelastic substance becomes minimal. And this is a fairly round rhexis. It is comparable to femtorhexis, though it is a manual rhexis. Now this is hydrodissection. My aim in this case is to tilt the lens by hydrodissection, and I am injecting some more fluid, and the lens stands like this. In this position, one equator of the lens is resting on the posterior capsule and the other equator is prolapsing out of the capsular bag, and it is projecting into the anterior chamber. It is above the iris plane. Now viscoelastic substance has been injected on either side of the lens, and now I take at least 3 attempts to enter into the anterior chamber with the tip of the phaco handpiece. Now here it is. I apply ultrasonic energy into the nucleus few millimeter away from the equator that projects into the anterior chamber, and a piece of nucleus has been emulsified and taken out. And now I rotate the nucleus and I hold it here and I tilt it again. So this is actually double tilt. First tilt, a portion of nucleus has been removed, it has been rotated, and it has been tilted again. And now I try to catch hold of this remaining portion of the nucleus, and I become successful at several attempts. If there is no surge, if the anterior chamber is stable, we can safely emulsify a soft cataract in this way, and we need not make any trench. We need not try to divide and conquer a soft cataract as described by some gurus of phacoemulsification. And now I remove the cortical matter. I have used a direct Simcoe cannula in this case. You can use a bimanual irrigation aspiration if you want, but this simple instrument works very well in my hands. Even I can polish the posterior capsule with this very simple instrument. And now viscoelastic substance is injected into the anterior chamber. Now I am polishing the posterior capsule with only irrigation. Regarding cleaning of cortical matter, I would like to say that Dr. Rastagi, long back in 1990-1991, Dr. Rastagi used to do refraction with a plane mirror, and he could detect the axis of the cylinders very well with plane mirror. I have never been able to do that. I have used strict retinoscope. So if you become very comfortable with an instrument, and if that instrument works wonders in your hand, it's fine. I have injected viscoelastic substance in the capsular bag in the anterior chamber, and this is a hydrophobic acrylic intraocular lens that has been placed in the capsular bag, and this is the ideal rhexis. The rhexis margin, the anterior rim, has covered the lens all around. So the rhexis size is about 5.5 millimeter in this case. It has covered the intraocular lens all around equally. Now, thorough removal of viscoelastic substance is very important. I go behind the IOL, irrigate BSS in the capsular bag, and I allow the viscoelastic substance come out through the main incision. Then I use the irrigating probe of the bimanual IA. Here it is. The irrigating probe is used to irrigate the anterior chamber. Again I go behind the IOL, irrigate the area, the space of the capsular bag behind the intraocular lens. Again I come in front of the lens and irrigate. And when I become satisfied that yes, I have nicely removed most of the viscoelastic substance, I use both irrigation and aspiration. Here it is. And now in this case I have not used the aspirating probe. Moxifloxacin has been injected into the anterior chamber. The side ports have been hydrated to make the side ports waterproof wounds. And now this is the final wash under higher magnification. That's it. And this is the final wash to form. Just before forming the anterior chamber, I form the anterior chamber like this and conclude the case. I check whether the side ports are watertight or not, and that's it. Thank you very much for your attention.